Evening. I'd like to welcome everyone to tonight's MSIG webinar, where we are continuing the series on textbook injuries, where each speaker will share their expertise on a specific sport and identify the most common injury or injuries from the sport. It's an honor to have the following AMSSM members serving on our five-member speaker panel. Dr. John Tobey will give a presentation on Nordic combined. Dr. Mark Niedfeldt will give a presentation on freeskiing. Dr. Samantha Stuek will give a presentation on biathlon. Dr. Klein will give a presentation on downhill skiing. And Dr. Ehn will give a presentation on snowboard. My name is Jennifer Addleman, and I am the MSIG Vice President, and I will be serving as the moderator for tonight's event. I am a fourth-year medical student at Touro University, California, pursuing PM&R. After all our speakers have shared their presentations, I will serve as the moderator for a Q&A with our speakers. During the webinar, please enter your questions into the chat, and I will read through each question during our Q&A segment. And now it's my pleasure to introduce Dr. John Tobey. Dr. Tobey is a board-certified physiatrist at Spine West in Boulder, Colorado. He did his medical school at the University of Utah. His PM&R residency was at the University of Colorado, where he also completed a fellowship in sports and spine. He's also board certified in sports medicine, EMG, and pain medicine. Dr. Tobey works with the United States Ski and Snowboard Association. He is also a medical director for the Boulder Valley Care Network. Dr. Tobey, you have the floor.
Thank you, Jennifer, and thank you, Joan, for setting up the this discussion here. Let me just share my screen here and we'll get rolling. And thanks to all of you for joining us this evening. I hope you find it helpful. Let's get going. All right, so I'm John Tobey. I work usually with the Nordic combined team and have done so for about the last 10, 12 or so years. So basically Nordic combined is a little bit of the unknown in the winter sports. It's a combination of ski jumping and cross-country skiing. And so it's a competition that typically starts with the jump. The jumpers get a score, and then oftentimes the cross-country ski race is based on the score from time bonuses based on the jump, and then the ski race follows. There are some different events. It is on the World Cup circuit. It's men's and women's. Unfortunately, it is the one winter sport that it's only men's at the Olympic level. The women have yet to be granted into the Olympics. But it's a super exciting sport. It takes a lot of training and a lot of discipline for two extremely different sports, ski jumping and cross-country skiing. So it's quite exciting in its own right. So basically, how did I get involved? Well, I grew up in Colorado. I did my undergrad and medical school out in University of Utah in Salt Lake City, and then my residency at the University of Colorado and fellowship there as well. I currently work in Boulder, Colorado as a physiatrist. I haven't strayed too far from the Mountain West. I always say that I perspire too much to live on the East Coast or the Southeast anywhere. So I love the winter sports. But a number of years ago, I did a volunteer rotation at one of the Olympic training centers and worked with a physical therapist for a couple of weeks at that time that was involved with the U.S. ski and snowboard teams at the time, and that was the in for me. So I put my name in the hat and was fortunate enough to start working with some of the teams. I originally worked for a couple of years with some of the disabled ski team and the Paralympians, and then have for the last number of years just predominantly worked with the Nordic combined team. So I'm fortunate enough to be able to travel to Europe typically for a week for one of the World Cup venues. So I've been to a number of pretty cool places, and those of you who have maybe have seen some of the ski jumping, they're sometimes in a little bit of a remote area, so they're not exactly in the right in the big cities. So it's pretty cool to traipse around Europe in the middle of winter and get to see some pretty awesome athletes. So that's how I was involved. I just pulled this since I'm the first speaker just to let you know about the U.S. Ski and Snowboard Association. This is the application requirements for the physician pool. Don't take notes because this is on their website. So, but basically, it is it's a privilege and an honor to be able to travel with them. It is a volunteer position, but there's nothing cooler than being able to go over to Europe in the middle of winter and help out. So one of the things we'll talk about is the kind of fourth line from the bottom there is every year they have a medical emergencies in skiing and snowboarding course, and you have to take that every 4 years. That's a pretty cool course. I'm signed up for that. That's in January here. So we're actually on the hill for a portion of the course. Sometimes a pretty steep pitch. So you do have to be able to navigate on skis, but doing some real life scenarios with the as far as packaging them up on the sleds and whatnot. And so thankfully, being in Nordic combined, we do see some injuries off the ski jump, but nothing quite like Dr. Klein might and some of the other speakers might speak of as far as with some more of the speed sport and the downhill. So one brief biomechanics for some of you. I'm not going to go into it very much here with the sport, just because we're going to go on to the treatment and some of the injuries. The biomechanics is ridiculous. The ski jumping has the in-run, the takeoff, the flight, the landing. All of them have different varieties of it. Skate skiing in and of itself is such a very different sport for many. So common injuries that we see there again, because there's two different disciplines, we see a variety of different disciplines depending on whether it's a crash off the ski jump, such as concussions or back pains, or a little bit more of a trauma injury, or the more common injuries with the cross country component is more of an overuse with the knee, in particular patellofemoral, patellar tendonitis, some of the ligamentous injuries or sprains or other tendinopathies elsewhere in the body. But you name it, you'll find it at some level, just because the sports are so different. So real briefly on patellar tendinosis, that's probably one of the more common injuries that we do see. It's an overuse injury, also called jumper's knee, typically pain inferior to the patella. So you can remember that the quadriceps tendon is above the patella, the patellar tendon is below. Treatments, NSAIDs, typically topical or oral. Physical therapy is very helpful, and that's where they're going to spend most of their time doing some of the eccentric based exercises. You can use a patellar tendon strap, can be helpful in some instances, which is just a strap that goes across the patellar tendon and just changes the biomechanics of the tendon. As with any weight-bearing tendon in the body, you want to do your best to avoid injecting cortisone here. And so be cautious with injections for patellar tendonitis or tendinosis. So let's see, what else do we got? I think that's about it. So once again, Nordic Combined, super cool event, ski jumping and cross-country skiing. It is an Olympic sport. Keep an eye out for it. It's a little bit less known than some of the other sports. Let me stop sharing here and we can go on. Thanks, Jennifer.
Thank you so much, Dr. Tobey, for your excellent presentation. Now it's my pleasure to introduce Dr. Mark Niedfeldt. Dr. Niedfeldt earned his medical degree from the Medical College of Wisconsin. He completed his residency in family medicine through the Medical College of Wisconsin and subsequently completed a fellowship in primary care sports medicine at MCW. He is the founder and owner of Collab Concierge Physicians in Macon, Wisconsin, and serves as team physician for the Milwaukee Brewers, the U.S. National Snowboarding and Freeskiing teams, Wisconsin Lutheran College, and Concordia University. He formerly worked with the Milwaukee Bucks, Milwaukee Wave United, Milwaukee Rampage, and Milwaukee Ballet. He previously served on the board of directors for the American Medical Society for Sports Medicine and is the current president of the AMSSM Foundation. And now, Dr. Niedfeldt, you have the floor.
Thanks, Jennifer. Okay, I've been asked to talk about free skiing. And to start out, I'm just going to kind of show you a quick video just to give you an overview of sort of what we're looking at. So obviously a lot of things going on here. What I'm going to do with this is concentrate mainly on the Olympic disciplines of free skiing. There's freestyle skiing and a lot of different things that are going on, but free skiing itself involves a lot of tricks that we saw in the video, jumps, terrain park features, rails, boxes, things along that line. It really grew out of a lot of the snowboard terrain park types of things, and then the skiers jumped in there with the dual tip ski, and now they can go forwards, backwards, and have a lot of fun as well. So currently there's 4 Olympic free ski events: ski cross, half pipe, slopestyle, and big air. So looking at the evolution of freestyle skiing and free skiing, freestyle skiing was contested in 1988 at the Calgary Games, and there were 3 events for men and women: moguls, aerials, and ballet. And if you have not seen ballet skiing, jump on YouTube, look it up. It's kind of awesome in its own way. Ballet did not go any further than that, but moguls went on, and that kind of split off. Aerials in 1994, and then ski cross came in 2010, followed by slopestyle half pipe in 2014, and then big air in 2022 at the Beijing Games was a new event. So looking at these different events, for those of you who haven't seen them, ski cross is a timed event. So you have 4 races going at the same time around a set track, and it has a number of jumps, sharp turns, obstacles that they go through. Plus you have the fact that there's 4 people on the course at the same time. When I was covering snowboarding initially, and this came in, it was kind of awesome because it was sort of a free-for-all. It was jacket grabbing and elbowing, and it was kind of a NASCAR type of thing. And now it's become more Formula One with a lot more rules, but still a very exciting event to watch. Half pipe, I think everybody's seen this somewhere along the line. So skiers doing a number of tricks. Understand that the walls of the half pipe are 22 feet high. When I first started covering, they were about 12 to 15 feet high. So this has gotten a lot bigger. The pipes have gotten bigger and they're longer. They're about 600 feet long on average. But understand that in that 600 feet, a lot of times there's maybe 7 or 8 tricks that are being thrown. So they are traveling a tremendous amount of distance with each trick that they're doing. Slope style was shown in that video. So you have a course with a number of obstacles. Typically there's 3 to 4 rails or other man-made obstacles at the top of the course, followed by 3 jumps that you see over on the left. These are huge jumps. They can be 40 feet tall, 30 to 40 feet tall, with kickers on them. The distance between sort of the edge of the jump and the knuckle, which is the landing, is typically around 50 to 70 feet. So a lot of times these skiers and snowboards also are traveling in the neighborhood of 70 to 90 feet in the air when they're going through a jump. So they generate tremendous amounts of force and velocity to get through this course. And then finally, big air is the newest one. So this sort of came out of X Games and a lot of different things where you have one jump. Beijing had this monster 120-foot, basically ski jump that the skiers went off, and then you perform one trick and try to land it. So a couple things on judging, just so you understand a little bit when you watch these sports, what they're looking at. So there are 5 different things that the skiers are judged on. And that's the first one is amplitude. So this is more than just height. It's also, are they under control as they go up? How are they landing in the sweet spot? Are they landing where they're supposed to land? Are they landing high? Are they landing low? So it's not just how big can you go, it's big under control. Difficulty is pretty self-explanatory. It's a technical difficulty, but it's not just rotation. So it's very different from sports that you see like diving or even ski aerials, which is very much like gymnastics or diving, where you have grades basically on how high you go, how many spins you do, and how you land. Where this is more the technical difficulty as far as rotations, how did they enter the jump? Did they come in forward or backwards, also called switch? What type of grabs did they do? Which direction are they spinning? Are they spinning uphill or downhill? All these things go into making the level of difficulty for what they're doing. And then variety. The judges want to see a diverse mix of tricks. So I've seen runs before where people go down and they do a ton of spins, but there's not much else into it. They're not going inverted. They're not doing anything unusual. It's just the number of spins, and that's not rewarded. So very different than figure skating, where hitting a quad is everything. Here, you can do a 14, but if you're not doing it in mix or with a combination of other things, you're just not going to get the scores. And then execution is, were you under control? How long did you hold your grabs? What type of grab did you do? And then finally is kind of the progression. So really what people like to see in this sport is introduction of new tricks, new sequences, combinations of doing tricks. So what we see at this sport is just making tremendous strides over the last, the last decade. It's been huge. I mean, you think of, double corks and different things that, Shaun White was doing back, 10 years ago. And now every, 15-year-old at Mammoth is throwing these down. So there's just been a huge progression of the sport. So how did I get involved in this sport? So I started covering the U.S. snowboard team in 1997. I know that's probably before some of you were born. It was a situation where one of our athletic trainers where I was working moved out to Park City, started working with the snowboard athletes, and they were starting to form a medical pool similar to what they had with alpine skiing. And at that point, all the big names, Stedman Hawkins, and nobody wanted anything to do with snowboarders. Nobody liked snowboarders, so they were looking for doctors. So our athletic trainer said, hey, I know a couple guys back in Milwaukee who would be interested in doing this. And we started doing it. At the beginning, it was unbelievably disorganized. They would tell me to show up in this little town in Europe. Hey, be in Kaprun, Austria on this date. And it would be the day before I'm leaving. And I'd say, hey, where are we staying? And they say, yeah, we don't really know. So it was a little, you had to be very flexible and willing to kind of wander around and figure out things on your own. Since that time, it's obviously improved and it's much more organized at this point. I've maintained my pool status and really done a trip just about, I think I've missed outside of the COVID year, maybe one other year that I've not done a trip with a team. I started moving over from snowboard to free ski and now I do both, but I've done free ski the last several years, before half pipe and ski slope were added to the Olympics in 2014. So looking at the biomechanics of this, just real briefly, I mean, I can't get into everything that these guys and girls do, but really a couple basic things that you want to understand. So the first thing is, as they come and they're coming to the lip of the jump or that pipe, they're going to want to pop off of this. So they want to generate speed coming in and then extending their knees and hips as they come off to really pop to gain your takeoff as you're moving through. As far as rotations, what you can do is as you watch these athletes, and you'll see they'll initiate the rotation before they pop. So you can see here, this is David Wise in his 2014 gold medal run. And as he's coming up to the edge of the half pipe, you can see he's already starting to rotate. He's kind of loading here, and then he's starting to come through. So as he's taking off, he's already rotating his upper body and his torso. And then you can see he's leaning. So he's leaning heavily initially on the right. And then as he comes up, then he's going to pop and then rotate to the right. And then you can see he's also leaning backwards, and that'll give him even more height as he's taken off. In the air, adjustments can be made by moving your body. Skiers have poles, so you can, how you're holding your arms, how you're holding your poles, what you're doing, how much you tuck will determine how far you fly and how many rotations you're going to do. And then obviously spot the landing. Injuries. So this is a sport where, there's a significant number of injuries that we see. Study done in 2010 and 2011, there's a couple studies done looking at injuries around World Cup freestyle skiers. So this did include moguls and aerials along with half pipe and ski cross. But what they found is that, with 662 athletes, they had 291 injuries. So very significant injury rate, upwards of 40%. Out of those injuries, 26.5% were no loss of time. So really pretty mild. But you look at it and say, okay, there's about 73.5% of the injuries were severe, and of those, or were loss of time, and of those, 93.4% were severe, which meant over 28 days lost. So it's one of these where you either get up and ski away, or you may be down for a while, depending on the injuries. Looking at the graph on the left, we can see, number one injury, as expected, is going to be knee, followed by head, face, shoulder, and then lower leg. I've seen actually a lot of ankle and foot type of stuff. A lot of it's from landing, and they'll get injuries there. But the number one injury by far is knee. So just looking at the knee, so that's 26.5% of overall injuries, and almost half of those were severe, mainly ACLs, followed by MCL meniscal tears. If we look at ACLs, three main mechanisms of injuries that we're going to see. First is the slip catch mechanism. So this is where the skier comes through. They've got their weight on the inner edge, they lose, and then, on the outer edge, they lose. And then regain on the inner edge, which then forces their tibia into internal rotation and valgus stress. Second mechanism is going to be landing back weighted. So that's going off a jump or something along that line, or a bump, where they land legs extended on the back tips, on the back of the skis. Boot makes contact, and as a result, you get this internal rotation valgus stress. And then you get this anterior drawer from the boot that's going to occur. And then finally, the dynamic snowplow. So what we're seeing here is, again, the skier loses contact with the inner ski. So the ski goes out, but the knee that ends up getting injured is actually the contralateral knee. So you can see here that internal rotation valgus stress as they catch that inner edge. And they don't always go down. They'll sometimes ski away from that, but they'll know they're injured. So really, if we look at this, I think the exam skills are pretty self-explanatory. You want to have a good knee exam. You want to have, a good shoulder exam, good concussion exam. And then this kind of reiterates, what we talked about earlier as far as being aware of how to get athletes off the snow. Treatment recovery, again, ACL is most common. So it's going to be reconstruction followed by rehabilitation. And that's what I have.
Thank you, Dr. Niedfeldt, for your outstanding presentation. And now it's my pleasure to introduce Dr. Samantha Stuek. Dr. Stuek is a primary sports medicine physician at the Hospital for Special Surgery and is a member of the Women's Sports Medicine Center at HSS. She earned her medical degree from New York Medical College, and she completed her residency in family medicine at Inova Fairfax Family Practice in Fairfax, Virginia. She grew up in Connecticut and returned to her home state to complete a fellowship in sports medicine at the University of Connecticut. Dr. Stuek currently sees patients of all ages at HSS and serves as a co-team physician for the United States Biathlon team and is a team physician for St. John's University Athletics. And now, Dr. Stuek, you have the floor.
Thank you, Jennifer. Okay, so I'll be talking today about the biathlon. So my journey to the biathlon, so I did not grow up doing cross-country skiing or biathlon. I actually did team sports in track and field. I did go to college for field hockey and track. I tore my ACL, which then eventually led me into the field of medicine and sports medicine. And as I continued in my medicine journey, I gravitated to more and more endurance sports. And when I graduated from fellowship, I wanted to take care of more endurance sports. I had the opportunity from my co-team physician who invited me to the 2023 Youth and Junior World Championships in biathlon in Kazakhstan. I was definitely unfamiliar with biathlon and unfamiliar with Kazakhstan as well. But as a young physician, you take opportunities when you have them. And so I said yes, and was definitely a great opportunity for me. I definitely had not been cross-country skiing before, so this is a picture of me down below trying it out for the first time. I've been downhill skiing before, and I thought it was similar, but this was definitely different, definitely fell a couple times. So definitely a great appreciation for how amazing these athletes are. And since that opportunity in Kazakhstan, I joined the national team in the summer of 2023. And then I've been to Östersund, Sweden, Novo Mesto non Moro in the Czech Republic. And in January, I'll be joining the team for their World Cup in Anhalt, Italy, which then in 2026 for the Olympics, that will be the area where the biathlon will take place. So I always find it interesting as well that I ended up in a winter sport. My husband likes to say that I don't tolerate the cold, but it's all about how many layers that you wear. So the picture on the right is me with all the layers that I'm wearing. And my favorite layer are my heated gloves. Okay, so what is the actual season like? So it goes from November to the end of March. And so this is typically what it looks like. I'm usually over by the rack, so I wanted to kind of show you all kind of what it looks like and where I'm located. I'm usually one of the first ones there to kind of stake out a rack for the United States. I'm helping them make sure they have their transponders, their bibs. Do they need any help with their warm up? And then I usually help walk them over to the start, which are those blue lines over to the left. If they have any like ice on their boots or anything, I'll help take that off for them. Now, even though the sport is mostly it's a winter sport, what does it look like in the summer? So this is usually what they do. So it's called roller skiing. So this is what the athletes will do off in their off season and in the summer training, most of the time in Lake Placid, New York, but they also are throughout the United States as well, and they're different club teams. And then during their actual season, again, from November to the end of March, they're most of the time all but in Europe. So it's kind of a gradual learning process about what is medicine like in Europe and how it's a little bit different than here in the United States. Important to think about what are the over-the-counter drugs that they have there versus what we have here. A lot of times they have herbal supplements, and always thinking about WADA and rules and regulations and helping to direct them. I appreciated this picture. So this is when I was in Kazakhstan, and just it's an EKG machine, so different than what we have, but just kind of a simple explanation about how it's different over there. So that was the alligator clips, and you actually had to ground it to the bed. So just kind of an example of how it is different. So a little history of the biathlon. So it is a combination of cross-country skiing and rifle shooting. It has its origins in the Scandinavian countries when individuals would hunt while on skis. And then in the 18th century, for training for military purposes, they started cross-country skiing as well as shooting. And that led to the debut in 1924 of the military patrol. So this was actually recently on the Olympic Instagram page when they were trying to promote the biathlon. This is what it looked like in 1924. The biathlon as we know it today actually debuted in 1960 in Squaw Valley, and then women were first allowed to compete in 1992. Okay, so going into what is biathlon, so they ski different distances and then stop at a rifle range, and they shoot both in the prone position and the standing position, so they're alternating each time they're taking laps. They shoot at 5 different targets that are about 15 meters away. When it's in the prone position, it's about 45 millimeters. So that's maybe like the size of a golf ball. And then when they're the standing position, the target's about 115 millimeters in diameter, a size of about a softball. So if you look at the picture on the top right, the small area in between is going to be the size of the target when they're prone, and then the larger area is going to be the target when they're standing. And if they hit the target, that little metal cover will close. The picture on the over on the right is what we call is like the paper targets. So usually before they shoot on the metal, they'll practice shooting on the paper targets. The coaches have these scopes to try to measure where the actual athlete is shooting and try to help direct the athlete as they zero in to kind of help with their practice shooting. This is what the rifle looks like. And so it has an easy harness. It weighs about a little less than 8 pounds. A magazine, which is those little red areas, has 5 different bullets in it. And then they'll have their skis, their boots, and their poles. The ski does kind of taper upwards, and then the boot is attached only at the tip. The different events, so there are a number of different distances as well as the different alternating shooting styles. The sprint is an individual event or like a time trial event. So the person who crosses the finish line first is not the person who usually wins. This is the shortest event as well. If they miss targets based on the number of misses, they do have to do a 150-meter penalty loop. The pursuit is actually a chase the leader type event, and it's based off the best 60 that did on the sprint. So the athletes will start based on how far behind they were in the sprint. And in this individual case, the person who crosses the finish line first is the winner. The individual event, again, is kind of that time trial like event. And then this is actually the longest one. So 15 kilometers for women, 20 kilometers for men. And instead of having the 150-meter penalty loop, they'll get a 1-minute penalty added on to the end of their finishing time. And then for the relays, now they have 5 shots, but now they get 3 extra spares as well. And after they go through their spares, whatever's left over, then they will have to do the penalty loop if they miss a target. So going into a little physiology, not too much, but biathlon is an endurance sport that requires high aerobic power, capacity, strength. The most important physiologic determinant of cross-country skiing performance is maximum uptake, or VO2 max, which is the maximum oxygen uptake that can be done in 1 minute. They are subject to different altitudes, different weather conditions, up to -20 degrees Celsius, as well as different wind factors. And during their skiing, they hit about a 90% max heart rate, and then they're able to lower that as they come into the shooting range to about 60 to 70% of their max heart rate. And they're able to train their breathing as well to try to shoot in between their breaths. And then this is a picture of doing the VO2 max testing, which is really cool. Usually you think about it on a treadmill, but if your main event is skiing, you can do it on skiing as well. Really cool to see as well. So they'll be able to test their VO2 max, how long they're able to keep their VO2 max, and then also their lactate threshold. So going into a little bit about the biomechanics of it. So during biathlon, they only do the skate skiing technique, but I think important to understand the classical ski technique as well. Oftentimes our athletes will do this as their cross-training technique. So when we look at what is classical skiing, this is what you think about as like running or walking on skis. But actually the biomechanics are technically totally different. So it's more of a kick and glide technique. So if you were to imagine kicking a soccer ball with 1 foot, that would be the force that comes forward on that one ski and then gliding along it afterwards. The picture down below is what we call as double poling technique. So most of the force coming from the upper body being transferred down and then gliding on the skis. This is a really good example. So for instance, if our athletes are having knee pain, ankle pain, or any other lower extremity pain, this is more force coming from their upper body. So it's a nice way that they can continue doing some cross-country skiing while also kind of not having as much pressure put on their lower body. So going into the biomechanics of skate skiing. So again, this is the main type of skiing that we use with biathlon. So this is going to be where the tips of the skis are pointed outwards and the backs of the skis are going to be a little bit closer together. The propulsive forces are going to be coming from the angled ski and then the transferred weight onto that glide ski, as you can see on the right. And then the different techniques as well with double pulling and using the strength from the upper body being put onto that as well. And what you'll see is if it's kind of an easier terrain, the angle tends to be a little bit smaller. If they're climbing uphill, the angle tends to be a little bit wider apart. Okay, so going into the injury, so relatively low injury rate. So much smaller. Definitely we get hit more with minor illnesses that hold our athletes back from training and competition, so upper respiratory infections. When we think about respiratory problems as well, definitely more prevalent with exercise-induced bronchoconstriction or exercise-induced laryngeal obstruction or ILO, which was previously called vocal cord dysfunction. If you haven't seen this, this can be really distressing for athletes. So it's this kind of like high-pitched kind of strider-like sound, happens right away kind of when they start doing exercise, and can be quite distressing. Usually have trouble getting air in. Oftentimes this is a reversible compression of the larynx, and usually they just have to do practice breathing techniques. Then when we actually look at the injuries for biathlon, there are acute, but most of the time it is chronic. When we talk about the acute, these are going to be falls more often with the roller skiing, like I showed you in that picture. It is more often in training season. It can hit the lower back, the knee, the lower leg, and oftentimes it is related to running. The injury, though, that I wanted to talk about, even though it's not the most common potentially in biathlon, but it is more common in biathlon or cross-country skiing, and then also with running and military personnel, was chronic exertional compartment syndrome. And this is kind of like a textbook injury, so I wanted to go through that. So what is it? It's reversible increased tissue pressure in a restricted fascial space, which results in pain, cramping sensation, paresthesias or numbness, and at times weakness. This again is very different than acute compartment syndrome, which is oftentimes, so that's going to be a trauma, and that is a surgical emergency. This is related directly to exercise, starts about 15-20 minutes into the activity, and then improves with rest. More often than the lower leg, the forearm, the thigh, and the upper arm. More prevalent, as I said, in cross-country skiing, and then more prevalent actually in that skate ski technique, as I was talking about with the repetitive contractions. And the incidence rate is 13 per 1,000 skiers. Most often in the anterior compartment in 70% of cases, and then 95% of cases will entail the anterior and lateral compartment. Bilaterally, it's found to be 37 to 82%. Really important to think about your whole differential diagnosis when you're thinking about this. You want to rule out, is there a bone stress injury? Is there medial tibial stress syndrome, or what we call shin splints, popliteal artery entrapment syndrome, or anytime an athlete's complaining of cramping in their lower leg with exercise, always want to look up above as well, thinking about lumbosacral radiculopathy. So going into some anatomy, so what are the compartments of the lower leg? So we have the anterior compartment, so that's going to have the deep peroneal nerve, and that's going to function in dorsiflexion. And then the sensory compartment is going to be the little web space in between the first and second toe. The lateral compartment, which is the superficial peroneal nerve, and that's going to function in eversion or turning the ankle outwards. The superficial posterior compartment, so that's going to be the gastrocnemius, the soleus, and the plantaris, and that's going to function in plantar flexion. And then the deep posterior compartment, or the tibial nerve, and that's going to function in plantar flexion as well as inversion, and that's going to function with the sensory is going to be in the soles of the foot. So looking at the exam, most of the time this is going to be normal, but again, you want to make sure and rule out everything else. So want to rule out that there's not a bone stress injury. So again, you're going to palpate along the tibial spine, along the medial aspect of the tibia, and on the fibula, have them do that hop test, make sure that that is all normal. Look up above as well, making sure to assess everything with the lumbosacral area. But again, as I said, it's usually a very normal exam. Really helpful if you can have them exercise after you see them as well. Hard to do in the off office, they do understand, but if you are able to have them exercise, it's going to be a little bit more tense and tender in that compartment. And then also if you do a pre-exercise and a post-exercise strength testing, you may notice that there's a little bit of weakness. So for example, the anterior compartment helps with dorsiflexion. So you may notice that they'll have a little bit of a foot drop after exercise. Oftentimes we'll order imaging, but again, that's to rule out, do they have some sort of bone stress injury? Oftentimes that will be negative. Then you go on to further testing. The gold standard is compartment pressure testing. So that's the picture that you can see on the right, where a needle is entered into the different compartments, and then you assess the pressure. Having a positive test is going to be a pre-exercise of 15 millimeters, 1 minute post-exercise of 30 millimeters, or 5 minutes post-exercise of 20 millimeters. There are some studies that are looking into some other ways to test this using MRI pre and post-exercise or different forms of ultrasound. But again, the gold standard is really going to be this compartment pressure testing. And then what is the treatment for this? So you're going to trial a period of rest, rehab, and some biomechanics, either running biomechanics or the way they're skiing, whether or not like why they're placing extra stress on that particular compartment. But again, these are elite athletes, and so oftentimes they do end up needing surgery. So what is surgery? That's going to be a fasciotomy, either 2-compartment or 4-compartment, where the surgeon does go in and actually releases those compartments. While this is an invasive surgery, it does often lead to success in having the athlete return back to their elite level status. Awesome. I know the questions are at the end.
Thank you so much, Dr. Stuek, for your excellent presentation. Now I'd like to introduce our next speaker, Dr. Yana Klein. Dr. Klein earned her medical degree from the Kansas City University and completed residency at Loyola University Medical Center Emergency Medicine Residency, and then completed her sports medicine fellowship at the University of Colorado Hospital Sports Medicine Fellowship. Dr. Klein's clinical areas of interest focus on sports medicine, medical education, and ultrasound, where she is looking forward to new opportunities in her new position. She is a Denver native who enjoys sand volleyball, park days, hiking, skiing, cooking, and spending quality time with her family and friends. Please go ahead, Dr. Klein.
Thanks so much, Jennifer. And this is a very impressive group of panelists here. I had just completed fellowship in sports medicine, and full disclosure, have not yet gotten the chance to cover professional or Olympic coverage, but did get the chance to cover in Winter Park ski clinics, so a lot of recreational skiing, some of which I'm picking up this year to cover Copper Grand Prix half pipe, get to still pick up some shifts at the base of the ski clinics. And then hopefully get more involved with USOPC. So that's the US Olympic and Paralympic Center. And so pretty early in my career. So a lot of these other panelists can probably speak to covering in downhill alpine skiing more professionally, but I have had some experience more with recreational weekend warriors. And so that's kind of what I'm going to speak to today. So we're going to talk a little bit about downhill skiing injuries and medical management. I am at the CU School of Medicine in the Department of Emergency Medicine as an attending physician, and do work closely with a sports medicine fellowship, and then hopefully picking up sports medicine clinic at CU Boulder. So just in Dr. Tobey's neck of the woods too. So getting into the biomechanics of downhill skiing. So alpine skiing is kind of what we classically think of as downhill skiing in the Winter Olympics. It's one of their signature competitions. And it's often referred, it involves competitors down a snow-covered mountain slope. They're going down as quickly as possible, and it's held in a time trial format, as opposed to skiers racing one another. There's 5 different events when you take a look at Olympic events: downhill, Salem, giant Salem, Super G, and combined. And medals are offered in both men and women for each event. And so something that's really popular in Winter Olympics, hopefully one day I get the chance to cover. And so some of these other guys can probably speak to it. But it really combines really high-speed movements with constant adjustments to different terrains. And as you can see, there are a lot of different vectors and key forces that include gravity, friction, and ground reaction. So you can see how these different vectors and forces come to play today. Now you can see it's really important to keep that center of mass or gravity for these skiers to maintain their position and be able to do these really steep turns on very steep terrain and going down as fast as possible. So a lot of the muscle groups that are involved in stabilizing the athlete are quadriceps, hamstrings, and glutes. Obviously, as we discussed even previously in this panel, downhill skiing involves a number of other injuries as well, predominantly knee injuries, head injuries, and back injuries. But really today's focus is more on some of the joint stressors, combining these high-speed movements where the knees really provide as the shock absorbers, the hips provide stability, and the ankles kind of provide control. And you can see as your foot is kind of in this binding, how the knee can be positioned in a variety of different ways. So in hyperextension, valgus, deep flexion, and internal forces. And that creates a lot of stress on these shock absorbers that we have. So most common injury in downhill skiing that I've seen, and per studies, it's knee injuries and predominantly ACL tears, and oftentimes knee valgus during falls and over rotation. So ACL injuries account for about 1/3 of ski injuries, even though equipment has been evolving over the course of the past decade. Even most recent literature in 2020, the knee joint still represents the most frequent anatomical injury location for about 1/3 of all injuries. And so, and that's amongst both sexes as well. And then biomechanics contributing to some of these ACL tears. So when you're having these really high speed movements and sudden movements, that leads to all of this excess stress on the knee. You can see with valgus stress, improper landings, and specifically binding release issues that can cause a lot of issues with these forces up against the knees. So a lot of times it's the proximal tibial anterior shear force, lateral knee valgus movement, knee valgus angle, and external knee valgus plus tibial internal rotation movement. And so oftentimes as you have more advanced skiers go through, the failure of these ski bindings means the ski acts as a lever and creates a substantial magnitude of torque about the knee for a longer period of time, so much so that the knee can't sustain that stress and puts a lot of stress on that ACL. Causing acute injury there. And in kind of lower level athletes, that's not as much of an issue because the ski bindings tend to release a lot easier depending on how you set up your equipment. But in a lot of our advanced athletes, they want to be bound to the skis. And so that's something to really consider. So next time Lindsey Vonn decides to come into your ski clinic, whenever a ski talks to you about catching an edge, causing a twisting motion in the knee while the foot is fixed to the ski, that's really your cue to say, yeah, I'm really concerned about an ACL injury. A lot of times skiers will describe a pop in the knee, rapid swelling in the knee, difficulty walking or bending the knee, feeling unstable in the knee joint. That's a very classic presentation or kind of something that they would say when they come into the clinic or when you're covering on the slopes. And so other risk factors, if there's any kind of poor skiing technique, mistake, inappropriate ski bindings, landing awkwardly, or skiing on uneven terrain. And a lot of times you have to consider environmental conditions when you're covering these sports as well. And even fatigue. So if you're going on a really high endurance event and they're just fatiguing out, their core stabilizers are not going to be as strong. So they're higher risk of having these injuries. So really, it's your physical exam and clinical suspicion that'll kind of guide you to diagnosing these knee injuries. And then MRI is the gold standard to assessing these ACL tears and associated injuries. And so when we think about diagnostic exam skills, you guys are going to get this hammered home to you in fellowship and when you go through sports med, so we don't have to go through the whole video. But clinical signs are swelling. So oftentimes you'll see hemarthrosis in the knee, difficulty walking. A lot of times if you see a big swollen knee joint, you know that something is, there's an injury intra-articularly. And so that's something where you really have to raise your clinical suspicion for these guys. Where Lachman test is the gold standard. Obviously we have anterior drawer as well, but Lachman's test will be kind of your gold standard testing. Imaging, MRI will confirm this diagnosis, and x-rays are done in clinic typically, or from my experience, because we don't have an MRI machine, you have to get them to be able to get to an MRI machine, or if you're the team physician, find a way to navigate through that with your clinical suspicion. But with x-rays, you can consider pathognomonic signs, and I think this is just helpful for you guys. As students, residents, and fellows to kind of go through some pathognomonic x-ray findings just for board studying and things like that, where you can see a Sagan fracture, which we have seen quite a bit of at Winter Park. And that's when you have a bony avulsion at the anterior lateral ligament. And that's a really high specificity for ACL tear. And so that's really pathognomonic for an ACL tear if you see that on your x-rays. And then a deep sulcus or terminalis sign. And so that's depression of the lateral femoral condyle at this terminal sulcus. And that's where that junction between the weight-bearing tibial articular surface and the patellar articular surface of the femoral condyle kind of meet. I haven't seen that as much, but something that I think is important for you guys to know as you go through this journey in sports med and study for your tests. So treatment and recovery process, we kind of harped on this a little bit before, but RICE for acute care, resting, icing, compression, elevation. What you have on site with you, so whether or not you're working on site with ski patrol, whether you be in a clinic or whether you get some nicer equipment, that'll kind of guide your management. But typically what we have is an immobilizer brace. I typically hate them for most things, but ideally a locked hinge knee brace with crutches with weight bearing as tolerated in the acute setting, but really getting them to orthopedic surgery to discuss surgical versus non-surgical treatment, especially as we're talking about athletes that are higher level, Olympic level competition. If these guys are going to continue to pivot, do high speed sports, that's really important to get that ACL surgery and repair, and one of the most common injuries that we see. And then discussing strengthening and rehabilitation exercises. So making sure they work on their full extension, strengthening, stretching, and not just keep them completely immobilized as they're able to, as the swelling starts to go down, even prior to surgical intervention. That'll be really important to discuss with the athletes about. Just to get them back to where they need to be and to optimize preoperative performance as well, because it can help improve their outcomes down the line. And so recovery is different for all athletes. And I think any one of us can really speak to that. They say 6 to 9 months with physical therapy. I've seen it up to a year, up to a few years, even less than 6 months. And so everyone's a little bit different with that. Prevention strategies. So you'll find that like a lot of these sports that you'll end up covering, they're working on strengthening the hamstrings, quadriceps, really working on neuromuscular strengthening and conditioning and proper equipment maintenance. So it'll be really important to check the equipment and things like that. And then providing safe falling techniques, which a lot of the upper level athletes are already well equipped to do. Really what Lindsey Vonn said, it's not about counting how many times you've fallen down. It's about getting back up one more time than you've fallen. And so if you guys have any questions, I'm really good at recreational downhill skiing, but for some of the more Olympic coverage questions, that might be directed to some of the other panelists here. But thank you guys for having me. I'm honored to be here.
Thank you, Dr. Klein, for your outstanding presentation. Next, it is my pleasure to introduce Dr. Meredith Ehn. Dr. Ehn is a primary care sports medicine physician at the University of Utah in the Department of Physical Medicine and Rehabilitation. She has experience treating skiers and snowboarders throughout all stages of injury, from slopeside to on-mountain ski clinic, off-mountain orthopedic injury clinic, and in follow-up. She has covered NCAA, FIS, and World Cup events. She is the head team physician for the U.S. Para Snowboard and Para Alpine teams. Dr. Ehn, you have the floor.
Thanks, Jennifer. So I'm going to talk about my path first because it's a little bit non-traditional. And full disclosure, I came to snowboarding through skiing. But before medical school, I was a physical therapist. I specialized in orthopedics and sports medicine. I practiced for 9 years. And most of my practice was in New Hampshire and upstate New York. So in New Hampshire, I worked out of like a small garden center, which was perfect for sports-specific training. And I had the fortune to work with some really high-level high school athletes, up-and-comers from the Holderness School, NCAA skiers at Plymouth State, and then some of our current and former US ski and snowboard athletes before they were famous. And then when I lived in New Hampshire, I just spent my free time skiing. I worked as a ski instructor for 5 years. And then even when I lived in New York, I was traveling back and forth. So I think this combination of working in physical therapy background and as a ski instructor, it's really given me a unique insight and appreciation for biomechanics and specific movements of the sport. So when I decided to return to medical school, it was largely to pursue a career in sports medicine to gain a better understanding and be able to help my patients. So in choosing residency, I was trying not to be short-sighted and pick one that would prepare me well for sports medicine. I wanted a really broad PM&R training, but Utah had all of the things that I was looking for. And I was fortunate enough to stick around and do sports medicine fellowship here at the university. And I have to say, of the one single thing that's probably been the most impactful in creating my path towards ski and snowboard medicine, it's definitely that fellowship in primary care sports medicine. I did leave Utah for a little while, went and worked in Chicago in musculoskeletal and sports medicine. I thought I could live in a city again after having grown up on the East Coast, but the mountains just spoil you. So I ended up back in Utah doing musculoskeletal and sports medicine as well as adaptive sports medicine, and just happened to be in the right place at the right time when US Ski and Snowboard pulled in para-alpine and para-snowboard from USOPC about 2 years ago. So I'm the head team physician now for both teams. So this is probably going to look like a little bit of an advertisement for sports medicine fellowship, and then getting you to join the physician pool for US Ski and Snowboard. But I have to say, like, sports medicine fellowship is going to be whatever you make of it. You're going to be able to set up opportunities in a wide variety of sports. But I definitely capitalized on what Utah had to offer. So we have a D1 NCAA fantastic ski team. I covered their just conference events with my attendings, as well as championship events, slopeside, and in a tent at the bottom of the hill. I also had the opportunity to participate in research on ski and snowboard, snow sports safety, which took me to 2 different international conferences prior to and during fellowship. So it really provided an insight into how other physicians, biomechanists, and engineers are actually looking at the sport of skiing as well as the sport of snowboarding. So in addition to opportunities to cover slopeside, obviously you're in Utah, so you can ski in the beautiful terrain that you see on the left side of the screen. But on the right side of the screen, we all as fellows spent a day a week at the Snowbird Clinic, which is at the base of Snowbird, very much like the clinic at Winter Park. So we essentially saw everything that came off of the mountain that didn't get flown out down into Salt Lake Valley. And it was a fantastic experience to see people right at the time of their injury. And then, of course, there are other opportunities at Utah. You get to cover a lot of ice sports, World Cup speed skating, and then at the Utah Olympic Park, we covered bobsled, luge, skeleton, and all of these, and aerials too. So all of these experiences together really set me up well, I think, for covering snow sport as a head team physician. So how do you get involved? Number one, focus on residency, pass your specialty boards, pass sports boards. That's the first step. Second step, gain experience. Find a job that includes team or event coverage and also gives you the flexibility to potentially join the USOPC or the US Ski and Snowboard medical pool. So one note, and this might be a little bit too early for you guys, but you do have to present malpractice coverage when you do join the pools of USOPC or US Ski and Snowboard. So that's something that you would need to work into an agreement or contract with your future employer. And then after you've had about 3 years of experience, and this is somewhat flexible, you can apply to become a member of the US Ski and Snowboard medical pool, which the process has been outlined, but I'll give you kind of a link at the end. So when I'm traveling with the team, this is the advertisement for joining the pool. It's really awesome. You get out there on the snow really before the mountains open. You're with the coaches, you're with the athletes setting up the course. On the bottom left is basically myself and the medical staff. So when you're traveling with ski and snowboard, you typically have a physical therapist or athletic trainer. We often travel with our strength and conditioning specialist, our nutritionist. We have a full tech team for preparing boards, and then at least 2, if not 3, full-time coaching staff. And you spend most of your day out on the mountain. It can get pretty cold. But then typically in the afternoon, I have a good chunk of downtime. I can work on emergency action plans. I can work on documentation and just enjoy the espresso that exists in Europe and Scandinavia that we don't have here. So border cross is the kind of the highest risk, or where we see the most injuries in snowboard events. So the other competition, I guess, category would be banked slalom, so similar to slalom on skis. But border cross typically starts, you can see everybody kind of standing in the left tile up at the start, and they come through the starting run, which is a series of rollers, some tables. So they have to have a pretty good amount of momentum to get through. And then they're going to make a hard turn and start coming through the course. And this is a test of speed. With border cross, there are 4 riders, and they're all running against the clock. And if you look at the tile on the right, that's actually looking down the course. And you can see there are quite a few jumps, banked turns. You can't obviously see the end. It's quite a bit further down. So I try to position myself where I can see both the start and as much of the course as possible. So we all have radios. You're in communication with the coaches. There's typically a coach at the start, a coach mid-course, potentially somebody down course. But I'll typically have my physio or my athletic trainer about halfway down the course. And we've already kind of talked amongst ourselves and the coaching staff about where we see the highest risk portion of the course being. And that's where we tend to try and position ourselves. So the days are long. It gets very cold. I also wear heated undergarments, especially when we're traveling in Scandinavia. But there's always some downtime. And when you're traveling to these beautiful places, they have Nordic skiing, they have snowboarding, they have alpine skiing, and you do have some free time to go and enjoy yourself a little bit. The one thing I do want to mention is traveling with you and ski and snowboard, you have to be flexible. So we can't control the weather, and it's a sport very much dictated by the conditions around us. So I was in Finland, I think in February last year, and it was like -20 degrees Fahrenheit. And then a month later, we're in the Southern Alps and the race gets canceled because there is, like, believe it or not, 3 meters of snow. So like 8 or 9 feet in 2 weeks. And then it rained and everything slid. So we just kind of packed up our stuff and turned around and didn't even get out on snow. So I'm going to switch gears and just briefly talk about snowboarding injuries. And when we think about epidemiology, there are kind of 2 classifications of athletes. We have recreational athletes who we're going to see in ski and snowboard clinic, and then we're going to have the elite athletes. And I think their injury characteristics are different because obviously they're going to be positioned and riding slightly differently. And I'm going to focus on the elite athlete because I think the one case that I'm going to present is an injury that you don't want to miss. We definitely see foot, ankle, and knee as the most common area of injury in our elite snowboarders. So very briefly on the biomechanics, I think everybody's probably seen a snowboard, but it is relatively flat, rockered at the tip, so easier to turn, and then shaped, in other words, kind of narrower in the center. And in order to produce a turn, you have to either get up on the toe edge of the board, which is to kind of dig your toes in, as you see on the left, or on the heel side to kind of go in the opposite direction. And in between these 2 turns, which you're not seeing, is a kind of a flat time or downtime or latency when you're on the board. So you go toe side, the board flattens, and then you go heel side. So it's very much like just going edge to edge as you're cutting a ski into the snow. So some of the differences, though, between skiing and snowboarding obviously have to come down to, one, both feet are strapped into the board. You don't have 2 different body parts moving at the same time. And then you're also not using poles. So in general, it's natural for us to reach out to protect ourselves when we fall. So that's why we very often see wrist injuries in recreational athletes. And it's not that we don't see them in our elite athletes, it's just much less common. We also see shoulder dislocations for the same reason. And if you look at the athlete on the heel edge of his board on the top right, you can see that he's putting his arm down to balance, and he's actually got really great purchase in the snow. But if he were to just lose that edge, he's really set up for both probably a wrist and potentially a shoulder injury. When we talk about muscles that are activating during carving on a snowboard or jumping or any sort of a maneuver, it's a combination of muscles. It's almost like an isometric, but not exactly. And it's going to be a combination of your rectus femoris and vastus lateralis to stabilize the knee, and a little less so the vastus intermedius. Your tibialis anterior is actually on quite a bit more than in a ski boot because the board is softer and you've got different movement kind of fore and aft moving back and forth. Your lateral gastroc is firing more than your medial gastroc, and then your biceps femoris. So those muscles are co-contracting to stabilize the joints. And then, of course, the binding of the boot, it crosses the top of the foot. So it places a rotational moment through the midfoot, which is really why we see more foot and ankle injuries in snowboarding than we do in, say, skiing. So just a quick case, and this is taken from a snowboard clinic. So we had a 25-year-old female snowboarder. She was considered an elite rider. She was riding off piste. She hit a rock, tomahawked, which means she tumbled and pretty much rolled down the hill. Then she bounced off another rock. And she did kind of the initial assessment, felt okay, had some ankle pain when she stood up, but she was able to ride down to clinic. So when you're doing an exam, and this is true of whether you're in ski clinic or if you can take them to a warm spot off the side of the hill when you're assessing an athlete, you want to make sure that you're examining the joints above and below the area of injury. You want to make sure that you're doing a thorough neurovascular exam, checking pulses and checking sensation. And then you can start your actual inspection and palpation to some extent. So she was tender over the lateral subtalar joint, distal fibula, anterior tibiofibular ligament, and calcaneofibular ligament. So really that whole lateral ankle complex. She had some mild focal swelling, but not necessarily with what we would see when you have a fibular fracture. We didn't get a great range of motion assessment on her because it was guarded. And we did at least attempt an anterior drawer and talar tilt, which she actually tolerated well and were negative. So we then went to x-rays, and there are two arrows. I wasn't sure if you guys would be able to see the dotted thin arrow, but obviously the big yellow arrow you can see. It's pointing to this teeny, teeny, tiny chip kind of at the bottom or base of the talus. And that is a lateral process of the talus fracture. These injuries are very often missed, especially acutely, because they masquerade as lateral ankle sprains. So it's important to get 3 views of the ankle whenever you're suspecting an ankle injury, and include a weight-bearing view so you can look at the integrity of the talocrural joint or ankle joint to make sure there's no widening. And as I mentioned, this showed a lateral process of the talus fracture. And treatment at this point is really just making her non-weight bearing. She has a fracture, it's intra-articular with extension into the midfoot joint space. And we basically, you really don't want these athletes walking on it. She actually didn't have a whole lot of pain once we booted her up, but because of, it's such a teeny tiny chunk, because of the nature of the fracture, you still want her to be non-weight bearing, but have close follow-up with orthopedics in about 7 to 10 days to make sure that there's no movement of the fracture chunk. And that's essentially because 45% of these people develop subtalar arthritis. So you really want to make sure that you stabilize that teeny tiny fracture fragment. And believe it or not, talus fractures account for 10.4% of lateral ankle injuries that we see in this population. And it essentially occurs as a result of axial loading with forced dorsiflexion and inversion. And our treatment for her after she went and followed up with ortho foot and ankle, they kept her in the short walking boot. They had her stay there for 6 weeks. And the indication there is because it was non-displaced, so less than 2 millimeters, but still intra-articular. That's all I have. So here are some links to websites. So if you do want to check out the specific requirements for the medical pool, it's pretty easy just to Google I don't have a QR code, unfortunately. I couldn't get that figured out quick enough. And then I think there was a question in the chat about joining the MESS course, whether or not residents could. And we do have fellows who participate in MESS. I'm not 100% certain on residents. And there are other professionals who do sometimes join us. I just don't know if you would be able to participate fully or if you could audit the course. So that's something that if you're curious, you could certainly email US Ski and Snowboard. All right, thanks. That's all I've got.
Thank you, Dr. Ehn, for your outstanding presentation. Before moving to our Q&A segment, I'd like to express our gratitude to our speaker panel for their outstanding presentations and for sharing part of your evening with the resident and student members attending tonight's webinar. I'll now serve as a moderator for our Q&A. I know that Dr. Ehn already, it sounds like she answered the first question. I'm not sure if anyone else has anything that they want to add as far as the MESS course and if that's something that residents can sign up for. Okay, great. No additions there. Thank you, Dr. Ehn. And then another question for anyone, are there any opportunities for residents to get involved with the US ski and snowboard teams, or would they be open to having residents come for a rotation of some kind?
I can take that. So the home base, the COE, the Center of Excellence in Park City, there's only one full-time physician at COE. Dr. Jaron Santelli is the sports medicine director. There are quite a few physical therapists and trainers at the COE, as well as performance staff. So they do take physical therapy students who rotate through the University of Utah. Actually, I think they're the sports physical therapy residents. But I'm not aware of the ability for any medical students or residents to spend time at US Ski and Snowboard COE.
Great, thank you, Dr. Ehn. If there are no other questions, I'll go ahead and conclude. Before we conclude tonight's webinar, it looks like there's another question. Let's see. For the subtalar fractures, since you wouldn't know on the spot what the injury is, do you try to automatically make them non-weight bearing with any lower leg injury, even if it can walk on it at the moment?
I think if you have high clinical suspicion, so we did just based on our palpatory exam, and it was confirmed with imaging because she really wasn't as tender over the lateral ankle ligaments or the distal fibula as you would expect with an ankle sprain. So it was really quite point tender, a little bit more inferiorly on the ankle.
And I'll just a bit of trivia. The first injury I treated back in 1997 with the US snowboard team was a lateral process of the talus fracture. So they've been going on for a while.
I guess in those situations, it makes sense to definitely make sure that you're palpating the right spots for the ligaments and making sure that you're not missing something else. So I will go ahead and conclude. I want to encourage you to join us at the beginning of next year on Tuesday, January 7th at 8 p.m. Eastern Time for our next AMSSM Journal Club meeting. We'll feature 3 presenters. Dr. Josh Schultz will be our first presenter on the article Endocrine Profiles in 693 Elite Athletes in the Post-Competition Setting, and will be joined by his club mentor, Dr. Jacqueline McKenna. Grace Kugler will be our second presenter on the article Iron and the Athlete, and will be joined by her club mentor, Dr. Robert Demeff, who is also one of the primary authors of the article she's presenting. And Dr. Logan McCall will be our third presenter on the article Attention Deficit Hyperactivity Disorder and the Athlete, an AMSSM position paper, and will be joined by his club mentor, Dr. Austin Gillette. It has been my pleasure serving as the moderator for tonight's session, and I'd also like to thank everyone for attending tonight's webinar. Thank you so much, and this concludes tonight's webinar.